Let's talk about the history of using saphenous vein. The first bypass surgery that was ever performed was in 1960 by Dr. Getz, and he performed a right internal mammary artery to a right coronary anastomosis. So that was remarkable. That is not that long ago, actually, in the terms of medical history. That's not that long ago. In 1967, a Dr. Rene Favaloro performed the first bypass grafting using vein as the conduit. So that led to a whole new set of options for people, because instead of having just one mammary artery on one side and one on the other, now we have a whole length of saphenous vein that we can take. The saphenous vein is usually chosen because it's easy to get to, it's superficial, it can be taken at a different time than the mammary can be taken, it's long, it runs from the ankle all the way up to the groin, and because of the nature of the venous drainage of the leg, there's redundancy in the system. So we can take that vessel out and we can use that, and the blood can still find its way out of the leg without causing excessive swelling. All right, so fast forward now to 1986. That is when they studied the left internal mammary artery graft, and they found that it had superior patency, or the ability for it to stay open long term. And that became the gold standard for bypass grafting. So that is the most common graft that you'll see is a lima to the LAD or a lima to the diagonal. The second most common graft you'll see is using saphenous vein. So let's talk about types of harvest. There's different ways to get vein out of the leg. There's different ways to get radial arteries out of the arm. The original way of harvesting the saphenous vein was what we call open harvesting, which is a long incision that runs down the length of the leg. People would use scissors to dissect the tissue away from the saphenous vein. Any branches that they encounter would be tied and cut, and then the vein is ligated proximally and distally and taken out. Then it can be cut to size, it's ready to be used. The benefits to taking the saphenous with an open technique is that it doesn't require any special instruments. You basically use the same instruments that you would use for a vascular case. So it's no additional cost, it's easy and it's convenient. The problem though is that this incision is painful because it's so long. It took a long time to close, and it's susceptible to wound infection, which was one of the biggest problems with taking saphenous vein. Because of the problems with the open harvest and the length of the incision, people started using bridging, which is a series of shorter incisions that we basically connect underneath the skin bridges with scissors as we're dissecting the tissue out. So we can still circumferentially dissect the vein, and we can tie the branches, and we can get the vein out without a long incision. Instead, it's 3, 4, 5, 6 smaller incisions. So this was better for pain, it was better for wound management, but it still was painful, and they still had wound problems. So it was better, but just not great. The other benefit to bridging, again, is that it didn't use any special equipment. The only thing we added from an open harvest was maybe a retractor, so we could pull up the skin bridge, dissect underneath, and things like that. So it didn't require special tools. In 1995, a doctor named Dr. Al Chin, who was a physician, and then he went to school to be an engineer because he enjoyed the entrepreneurial side of medical devices. He actually invented an angioplasty balloon to help with coronary artery disease. Researching this, as he was watching this in the cath lab, oftentimes patients would go off to surgery, and he would accompany them to surgery. He had watched a lot of laparoscopic surgery using a scope and a camera to do surgeries in the belly, and he thought, well, why couldn't we do the same thing to take the vein out instead of this bridging technique or the open technique? Basically made this prototype, and he tried it on a pig, of all things, and found that it actually kind of worked. So he made the first prototype for endoscopic vessel harvesting. Now the benefits to this, one incision. It's basically just one incision above or below the knee. So very small incision to close, very small incision to cause pain, and a very small incision to create a wound infection. So he realized that he needed CO2 much like they use in the abdomen. So he integrated that into his design. That helps keep the tunnel open. So now he had a whole new way of doing things. So that was 1995, not even 10 years later. The Society for Minimally Invasive Cardiac Surgery said that EVH, or endoscopic vessel harvesting, was the new gold standard for harvesting conduit for bypass surgery. That's pretty incredible. So the obvious benefits are a small incision takes less time to close, it takes less time to heal, and it causes less pain. Patients loved it though, and the patients that had open harvesting or bridging and that then needed to redo surgery by the time EVH was on the scene, patients said, oh, I don't want to feel this leg pain. Oh, my dad had such terrible leg pain. I'm not looking forward to that. We said, oh, we don't need to worry about that anymore. And I even had a blind patient who had had a previous surgery. He complained about the leg pain before surgery. He said, oh, I don't want that. I don't want to go through that again. It was terrible. And the morning after surgery, he woke up and I checked on him. He said, why doesn't my leg hurt? That's what I remember from last time, and my leg is killing me. I said, no, we took vein from your leg. We just used a small incision and a scope. And he was blown away because he didn't even know it was there. So that to me was a testimony to how much patients like it and how important it is that we learn how to do it well.